Hi everyone, my name is Rachel Crabtree. I am presenting today with my classmates Claire Davis and Megan Smith. Thank you for having us at this gerontology conference. We are excited to share our topic, which is reducing delirium in hospitalized older adults. Before we dive too deep into what exactly delirium is, we need to talk about the background, its impact on older adults, and its significance and relevance today. Delirium is a neurocognitive disorder characterized by an acute onset of altered mental status, hallucinations, and agitation, contributing to severe complications and increased mortality in hospitalized older adults. Delirium has significant negative impacts on older adult patients, as it increases the chance of death while hospitalized by over 2.5 times compared to non-cognitively impaired patients. It also increases the incidence of falls, rehospitalization, anxiety, and depression. So, who does this affect? A delirium affects roughly 32% of adult patients and about 80% of older adults who are admitted into the intensive care unit. It significantly increases an older adult's cognitive and functional decline and is associated with high mortality rates, making prevention a key component toward improving care. There is a plethora of literature which tells us time and time again that delirium poses an increased risk for injury and other concerns for hospitalized older adults and commonly occurs within the first few days of hospitalization. These patients have extended hospital stays, increased risk for morbidity and mortality, and greater functional and cognitive decline. Delirium and dementia are often misdiagnosed due to their similarities and lack of education, making this a very pertinent topic for nurses to learn about today. There are several best practice recommendations which we will dive more deeply into during this presentation, but research has shown that involving caregivers and families in prevention strategies has reduced the incidence of delirium. In addition, utilizing caregivers in reorientation and focusing on non-pharmacological methods, such as sleep hygiene, has helped to prevent delirium from occurring. As we can see, delirium increases the risk of mortality and morbidity in hospitalized older adults, making it extremely important that we improve healthcare provider and caregiver education, along with implement evidence-based prevention strategies, which we will discuss further in a minute during this presentation, because this can reduce complications, shorten hospital stays, and improve overall patient outcomes. In order to identify and prevent delirium, we must first define what it is. So delirium is a medical emergency characterized as a sudden and acute cognitive disorder that results in cognitive impairment and disorientation, caused by multiple different factors, including surgery, illness, and medical complications. It is reversible and most commonly affects older adults in the hospital setting. With increased research and more advanced identification strategies, we now know that delirium affecting hospitalized older adults is a growing problem among all healthcare facilities. So this includes nursing homes, but it is most prevalent in the hospital setting. The DSM criteria characterize delirium as the rapid onset of symptoms that tend to fluctuate even during the same day with an altered level of consciousness, cognitive disturbances, and evidence of a physical cause or multiple etiologies. Delirium is often misdiagnosed as many nurses and healthcare workers continue to confuse the symptoms with dementia, making discussing and educating on this topic very, very important. The onset of delirium is commonly within the first few days of hospitalization. So this is very important for all nurses to keep in mind as they get a new admission or new patient who is an older adult. To keep an eye and be aware of the signs and symptoms of delirium. Delirium can also present in a hypoactive or hyperactive form. Symptoms may fluctuate as they are most prominent during the night and early morning hours. Hypoactive delirium is the most common form versus hyperactive. Here we have listed the DSM-5 definition of delirium. The key takeaways from this slide is that it develops within a short period of time. It involves a change in baseline attention and consciousness, and the severity does tend to fluctuate throughout the day. Another important factor is to note that disturbances cannot be explained by other pre-existing or developing neurocognitive disorders. So a patient who has dementia, for example, who's been slowly declining cognitively. There will be evidence from medical history, lab findings, or examinations that the disorder is due to the result of intoxication or withdrawal of a substance, somatic disease, exposure to toxins, or multiple etiologies. There are multiple etiologies of delirium, or factors which make an older adult more at risk for developing delirium, which are advanced age, neurocognitive disorders, so a patient who has dementia at baseline is at risk for developing delirium. Acute medical illness, adverse drug reactions, polypharmacy, use of restraints, whether that's chemical or physical restraints, as well as recent surgery. There are different forms of delirium, which are hyperactive and hypoactive. Hyperactive is what some of us think of more commonly when we think of delirium, which present as restlessness, agitation, hallucinations, mood swings, feeling that they are unsafe or having kind of a panic feeling when they are hospitalized. Hypoactive, it's important to note that that is the most common form of delirium, and it presents as lethargy, drowsiness, or confusion. A patient can also present with mixed delirium, which is literally just a mixture of the hyperactive and hypoactive, and these can fluctuate throughout the day. Since delirium and dementia are often confused with one another, it's important to define and state the differences between them. Delirium is a sudden onset. A patient will suddenly have altered mental status or suddenly have hallucinations, versus dementia, where a patient will have gradual cognitive decline over time. Delirium is short-term, so it occurs over several days or several weeks and is reversible. Dementia occurs over several months to years. It is irreversible and progressive. Exposure. As we learn more about delirium, it's important to keep in mind the factors which make older adults more at risk for developing it. As nurses, we love mnemonics, so this one is called DIMS, which stands for drugs, infection, metabolic, such as dehydration, which is electrolyte imbalance, or hypoxia, and structure and systems. So examples of that would be stroke, hypertensive crisis, or sepsis. Delirium in hospitalized older adults increases their risk for many comorbidities, especially if it goes unnoticed or untreated for a long period of time. Delirium comorbidities include longer exaggerated hospital stays, increased risk for mortality, depression, cognitive and functional decline, and increased need for institutional care. As nurses, we have unique roles within the healthcare system as being the primary bedside caretakers of our patients. This means that we can notice acute changes in their mental status before many other providers do, and we can advocate for our patients because of that. We must play an active role in preventing and identifying delirium and treating it in the early stages. This can cause a strain on nurses when resources are slim, and dealing with patients who have delirium can be a high-stress situation. Nurses themselves will often experience anxiety and stress when assigned to patients with delirium, increasing the risk of burnout and high turnover. It is important for us as nurses to learn about the prevalence, the impacts, and the major risk factors for delirium among older adult patients in order to help prevent and identify it. We must advocate for early treatment, as I stated earlier. And we also must collaborate with the entire healthcare team to reduce risk factors such as polypharmacy, bladder catheterizations, and physical restraints, since we know these increase the risk for delirium in hospitalized patients. We must also implement non-pharmacological interventions for delirium prevention. These are cognitive stimulation, reorientation techniques, encouraging nutritional intake, maintaining adequate hydration status, assisting with early and frequent mobilization, and providing vision or hearing support, such as glasses or hearing aids. In summary, we have learned today that delirium is an acute and reversible cognitive disorder that develops over the course of hours to days and is most commonly affecting older adults who are hospitalized. We have also learned that risk factors include older age, infections, adverse drug reactions, surgery, and any acute illness. Early recognition and management are essential to prevent prolonged hospital stays and further cognitive decline. We as nurses play a key role in identifying risk factors and implementing interventions to prevent delirium. This is a part of advocating for our patients, which is one of our major roles. Prevention through non-pharmacological strategies, such as reorientation and cognitive stimulation, has been shown and proven to prevent and reduce delirium. Hi.